Welcome to VisionCorps Presents. Today's topic is glaucoma, a no-pressure discussion about high pressure in your eyes. Please stay tuned for our speaker, Dr. Drew Chronister.
Okay,
Thank you.
everyone, I think we're ready to get started. I want to welcome everyone to our speaker series today, Glaucoma, a no-pressure discussion about high pressure in your eyes. And before I introduce Dr. Chronister, again, I just want to thank everyone for joining us. VisionCorps, is happy to assist you with all of your needs regarding your low vision and blindness. And we have a number of rehabilitation services available. And if you are not yet working with us as a client, we'd love to talk with you about our low vision occupational therapy that we have, our orientation and mobility services, our access technology instruction, our social work case management, and other groups and presentations like this one. So we look forward to hearing from you if you'd like to learn more about how VisionCorps can help you to restore any lost independence. So I'd like now to take an opportunity to introduce Dr. Drew Chronister. Dr. Chronister is on staff at Wills Eye Hospital, where he teaches residents and trains the next generation of cataract surgeons. He was one of the first eye surgeons in Chester County to perform laser-assisted cataract surgery and is pleased to offer state-of-the-art customized cataract surgery and intraocular lens options to patients. Of course, his other clinical interests include the treatment of glaucoma, about which he's here to talk to us today. He is a native of York, Pennsylvania, and currently resides in Chester County with his wife and 4 children. So, Dr. Chronister, take it away.
For having me. Just a couple of things that I wanted to cover today. And one is sort of talk about the 2 primary types of glaucoma, and then go over kind of the risk factors for glaucoma, and then talk about current glaucoma treatments. And so I usually start my talks out with some just basic anatomy of the eye. The eye has kind of a clear windshield of the eye. That's perfect. If you can go, Taylor, to like slide 5, which just says the healthy eye. So the way that we tend to see with the eyes is that light comes in and it's bent by the cornea, and it's bent by the lens, which is behind the pupil. And it comes to a point on the retina, which is the back wallpaper of the eye, kind of the photographic film of the eye. And from there, the retina absorbs these light rays and translates that into a signal, which goes all the way to the back of the brain, to the occipital lobe. And that track that it goes back starts out as the optic nerve in the eye. And so you really need a clear media for the light to get through. You need a functioning retina and macula, which is the center of the retina, and you need a working optic nerve and then brain to translate that image. And today, talking about glaucoma, it's really a disease of the optic nerve. And so next slide, Taylor. And so glaucoma is a disease where of the optic nerve that occurs when the pressure is too high for the eye to handle. And so a lot of people think of glaucoma as just high eye pressure, but one thing we try to impart on our patients is that it's really pressure that's too high for that particular eye to handle, and different eyes handle different pressures. When the pressure is too high for that eye to handle, the optic nerve gets damaged, and as a result, patients tend to lose their peripheral vision, and that tends to happen in a characteristic pattern. That's good because it's not the central vision. It's bad because patients often don't realize that they're losing vision. If you're losing a little bit of your peripheral vision each year, and it's a slow process, which it is for most glaucoma patients, then you can lose a lot of vision before you realize that you don't see as well peripherally as you used to. And unfortunately, we can't reverse or get back any of that vision that's lost in the periphery. And so it's kind of makes the importance of regular eye exams and screening eye exams, because if you wait till the patient's symptomatic, they're generally at an advanced stage of glaucoma and their vision loss is irreversible. And so glaucoma is one of the leading causes of blindness in the United States, and early detection and treatment are kind of key. Next slide. So the anatomy of glaucoma, we're really, even though it damages the optic nerve, which is in the back of the eye, the anatomy of glaucoma is really focused on kind of the front and middle parts of the eye. And that's because I think of glaucoma kind of like you think of a sink. The eye makes fluid and it drains fluid. This is not tearing or anything on the surface of the eye. This is all inside of the eye. And so the eye makes fluid in an area called the ciliary body, which is just behind the peripheral part of the iris. The iris is the colored part of your eye, whether it be blue or green or brown. So fluid's made behind the colored part of the eye, and it has to circulate to the front of the eye, and it does that through the pupil, which is the black hole in the center of the iris. And then that fluid drains in what's called the angle of the eye, and the angle is just in front of the colored part of the eye in the periphery. And so in order to maintain a healthy level of pressure, this constant production of aqueous fluid inside the eye and drainage of aqueous fluid needs to be such that the fluid doesn't increase and the pressure doesn't increase. Next slide. So there are two real main types of glaucoma. Open angle, which is the most common type. And Terry, you can just go to the next slide after this, sorry. Open angle, which is the most common type in glaucoma, and closed angle, which is less common in the United States, but is a more urgent form. Next slide. And so open angle glaucoma occurs when the fluid can get to the drainage part of the eye. The trabecular meshwork, which is what we call the angle, that's the part of the eye that drains the aqueous humor. The fluid can get to that part of the eye, but the trabecular meshwork is less efficient at draining that fluid. And so the eye makes fluid, but it can't drain it, even though when we look in, we see the drain and the pressure then builds up, and this can lead to optic nerve damage. Next slide. And so this happens, as I was saying, at different pressures among different patients. And so, as I already said, glaucoma was really thought to be pressure it's too high for that particular eye to handle, not just high eye pressure. And typically, glaucoma has no symptoms in the beginning stages. And so next slide. And we can actually skip that slide, Taylor, and we'll go on to closed angle glaucoma. And so in closed angle glaucoma, the colored part of the eye, the iris, the periphery of the iris is pushed forward, usually bowed forward, and actually blocks the trabecular meshwork or blocks the drainage part. And if this happens 360 degrees around the entire trabecular meshwork, the intraocular pressure, or IOP, will build up very quickly. And this is called acute angle closure glaucoma. Acute angle closure glaucoma tends to happen more often at night. It's an ophthalmic emergency whereby patients develop severe pain, oftentimes pain above the brow, redness of the eye, decreased blurred vision. They can become nauseous and vomit because the pressure is so high. And this is really a medical emergency. Next slide. And so this is actually a video just kind of showing that the drainage part getting blocked off by the color part of the eye moving forward. And so when this happens, what we need to do is an emergency laser procedure, and I'm going to talk about that in a little bit. It's much better to do this laser procedure prophylactically. And so we do screen patients in the office. And if we think that they're at risk of going into this angle closure glaucoma, then we do the peripheral iridotomy prophylactically. Okay, next slide. And so risk factors for glaucoma, the two biggest risk factors are elevated eye pressure. So as I said, some patients will tolerate pressure that's higher than quote unquote normal. Normal pressure is 10 to 21 millimeters of mercury. And that normal range is just a statistical normal. Basically, the normal pressure is about 15 with a standard deviation of 2.5 to 3 millimeters of mercury. And so 2 standard deviations gives you this 10 to 21 range. And so there are some patients who will tolerate higher pressures than that, but the higher the pressure, the higher the chances for glaucoma. And then the optic nerve appearance, how the optic nerve looks. Those are the two biggest risk factors by far. Other risk factors, family history, there is a genetic component to glaucoma. Age and race for Caucasians, age over 65. For African Americans, it's age over 55 that puts you at higher risk for glaucoma. And then thin corneas. So this is just something that you're born with, the thickness of your cornea, which is the windshield of the eye. And thin corneas probably increase your risk of glaucoma in part because when the corneas are thinner than normal, then the pressure that we're measuring is actually being underestimated. If they're thicker than normal, the pressure is being overestimated. Previous eye injury can increase your risk of glaucoma. Nearsightedness or myopia increases your risk of open angle glaucoma. Farsightedness or hyperopia increases your risk of closed angle or narrow angle glaucoma. And then diabetes and hypotension, those are two additional risk factors, but these risk factors kind of go from the largest risk factors to the smallest risk factors. So those are fairly minor. And so the best way to check for glaucoma is to have regular eye exams. And, because I said about the issue of some patients getting glaucoma with quote unquote normal pressure and some people not having glaucoma even though their pressure is high, just checking the pressure isn't enough. You really have to look at the optic nerve. Primary care doctors and neurologists often look at the optic nerve the way the picture is showing with a direct ophthalmoscope. We tend to use a slit lamp biomicroscopy where we use a microscope and a special lens and get a little bit of an enlarged view. And we can take fundus photos and do optic nerve analyses, and I'll show some of that in a moment. So it's estimated that 3 million Americans have glaucoma. That's about 1% of the population. Only about half of them have been diagnosed. And then there's about 3.5% of the population that are suspects, meaning their optic nerves look a little funny or enlarged, their pressure is a little bit high. And so those we often follow in a practice like mine, that's a comprehensive practice. You have some patients who have glaucoma, but you have a number of them that are just glaucoma suspects, meaning we're watching them. Next slide. And so what do we do during an exam? We measure the pressure. That's called tonometry. There are different ways that we can do that. The high pressure reading is often one of the first signs of glaucoma. And then next slide. And then we also look at the optic nerve. And so this oftentimes involves dilating the pupils. It doesn't have to, but you do get your best view with this. And there are two pictures for those of you who can see the images. Ophthalmology, unfortunately, is a very visual subspecialty. And so the image on the left is kind of a normal optic nerve. We're looking at where the blood vessels kind of dive back into the center of the optic nerve. That center part of the optic nerve is called the cup. When we look in our office, you can see it kind of in 3D. In pictures, you can sometimes get fooled, but one way to kind of cheat in pictures is that if you look at the optic nerve, the outside circle is kind of the size of the optic nerve, and then you can usually find a smaller, and that's usually orangish or sometimes pinkish. And then you can usually find a circle in the center that's a paler white. And so in the picture on the left, that optic nerve cup is pretty small and looks normal. The picture on the right, this is advanced glaucoma, where pretty much the entire nerve is excavated or cupped out. And you can see that would be, you can do, especially on the left side of the nerve, a difference between the outside of the nerve and that cup. But there are parts of that optic nerve where it looks almost like that central portion goes all the way to the edge. Okay. Next slide, which I think is a video, but we can skip that. And so the other thing that we often do, particularly for patients who are at high risk or have risk factors for glaucoma, is we check their peripheral vision. For those of you who have been taught in the past to check the peripheral vision in exam lanes, we kind of have the patient cover one eye and look at our nose, and we kind of flash fingers. Unfortunately, while that can be good for picking up things like homonymous hemianopias or bleeds in the eye or tumors in the eye, it doesn't really help that much with glaucoma until it becomes very, very advanced. And so instead we do use a visual field machine. And so in this machine, again, testing one eye at a time, the patient looks straight ahead at a light, and the machine maps out the normal blind spot. On the left, it's kind of the center image there. That is a normal left eye visual field. You see the little bit of black just to the left of the cross there. That's the patient's normal blind spot in the left eye. And patients who have glaucoma, as I said, tend to lose their peripheral vision in a few different characteristic patterns. And so the image on the right is what we would call a superior arcuate scotoma, whereby the patient has lost superior vision in the left eye. And so you can still see the normal blind spot, but all that blackness kind of above the horizontal line is vision loss from glaucoma. In general, peripheral vision problems in glaucoma tend to be top and bottom, superior and inferior, and respect what we call the horizontal meridian, which is the horizontal line on the visual field output there on the image on the right. Whereas neurologic causes or brain causes of peripheral vision problems tend to be more left and right, either within an eye or both eyes together, and that tends to therefore respect the vertical meridian or the vertical line on that test. Okay, next slide. And so during an eye exam, we check the pressure, we look at the optic nerve, and if they're at risk, we may get a visual field test. We may take special pictures of the optic nerve. And one of the best for these is called an optical coherence tomography, which is, as I tell patients, next slide, as I tell patients, kind of an analysis of the optic nerve. And this is really revolutionary technology that uses light beams to take images and incredible resolution. Its resolution is down to 5 microns or less. So as a reminder, a micron is 1,000th of a millimeter. And this machine can get up to 50,000 scans per second and kind of make a 3D reconstruction of the image that of the part of the eye that it's imaging. We image different parts of the eye in ophthalmology. You can image the front of the eye, you can image the optic nerve, you can image the macula. But because it's light rays, the light has to be able to get through. So you can't image right behind the colored part of the eye, for instance, because the light rays don't go through the colored part of the eye. You have to go, the very front of the eye, or you have to go through the pupil. And so in glaucoma, you get structural changes to the optic nerve, and specifically to the retinal nerve fiber layer, the RNFL, which is diagnostically associated with the visual field losses. So next slide. So this is an example, for those of you who can see, of an optical coherence tomography of the RNFL in a normal eye. And so you see the upper left picture of this is just a red-free image of the optic nerve and the retina, and you see some of the blood vessels there. Underneath that is a color-coded map that is looking at the thickness of tissue around that green circle. And so in each of those, not really quadrants, but sextants, it gives you a value for how thick the retinal tissue is there. And then the center the number in the very center of that, in that central circle, is the average, or what we call the global. And so green is good. Green means it's normal. Yellow would be borderline. Red would be abnormal. But that's compared to a normative database. And so where this test really has value, this initial image is somewhat helpful, but the technician has to center the optic nerve within that green circle, and then that patient is being compared to a normative database. Where this test really becomes helpful is subsequent exams on the same machine. The machine will recognize the anatomy and lock on the green circle to where it was initially placed. So once you do the second, third, fourth, and subsequent tests, the machine actually decides where it's putting that green circle, and it's matching it to where the green circle was on the first exam. And by doing that, you can then follow a patient over time to see, are they losing nerve fiber layer tissue in a particular area or globally? And so you can compare a patient to themselves, a few years earlier. If you go to the next slide, and this is advanced glaucoma. And so this, is a extreme example. But I like it because, again, when I was talking about the optic nerve cupping or the enlargement of the optic nerve, you can really see that on this red-free image, right? That bright white part of the optic nerve on the right side is taking up most of the optic nerve from top to bottom and from the center to the right. And you look underneath, and that's exactly where the retinal nerve fiber layer is very thin and therefore is red. On the left side, or the nasal side of the nerve, it's yellow or borderline. And I know this is too small even for those of you who are able to see these images, but for instance, this average nerve fiber layer, the central number in this nerve is about 48, and I think it was about 96 on the normal one above. So about half of the nerve fiber layer has been lost in this example of advanced glaucoma. Next slide. So the other thing that we look at, and this gets back to the two different types of glaucoma, is we do gonioscopy, which is where we can actually look at the drainage of the aqueous humor, the angle or the trabecular meshwork. And so we have to put a special contact lens on, and that has mirrors that allows us to look in the mirrors and see the angle, which again is the in front of the color part of the eye and the very peripheral part there. And so this is the main test that we do to determine if a patient is open or closed, as we say, and therefore if they have open angle or closed angle glaucoma. Next slide. Besides open and closed angle glaucoma, there are a couple secondary causes of glaucoma. Some of it is medication induced, so steroids, and this is one of the biggest things that I see in my practice. Patients who are on steroids, and it's really steroids of any type, the steroids can increase your intraocular pressure, and if it increases it more than the eye can handle, the patient can get glaucoma. And so we see this with cortisone injections in a joint. We see this quite commonly now that Flonase is over the counter with patients who use chronic Flonase as a nasal spray. We don't see it as much with steroid eye drops, because if they get steroid eye drops, they're generally prescribed by an eye doctor, and we're watching for that. Oral prednisone, again, most of the time that's not a chronic, but sometimes you get patients with lung disease, asthma, COPD, or rheumatologic diseases that are on prednisone episodically but fairly frequently, and so those patients can have a secondary glaucoma from the steroid. Anticholinergics, over-the-counter antihistamines, decongestants, these are things that often say if you have glaucoma, don't take this. And while that warning label is good, it can be a bit problematic from the standpoint that that's really only in the closed angle glaucoma patients. So open angle glaucoma patients, or patients who are at risk for open angle glaucoma, the over-the-counter antihistamines, decongestants, those medicines do not have an effect on open angle. They tend to close the angle more. So somebody who's predisposed to angle closure should not take those medications. And then sulfonamide medications, topiramate being the most common, can cause an idiosyncratic swelling of the ciliary body, which is bilateral. This is we don't see this very often, but when we do, this is a big problem because the laser that we normally use for angle closure does not resolve this angle closure. Really, the only thing that resolves it is stopping the Topamax and treating the pressure, while the Topamax is wearing off with either drops or oral medicines. Neovascular glaucoma is a secondary cause of glaucoma that's particularly difficult to treat. Comes when there's a lack of retinal blood oxygenation from either ischemia or a vein or artery occlusion in the retina, or advanced diabetic retinopathy. And these, when this occurs, new blood vessels form. They can form in the back of the eye, they can form in the angle. And when they form in the angle over the trabecular meshwork, it can cause the pressure in the eye to go up. Next slide. There's a secondary cause of glaucoma called pseudoexfoliation. Tends to be more common in Northern Europeans. There's a genetic predisposition to this, and this is characterized by deposition of this pseudoexfoliative material on the anterior capsule of the lens inside the middle of the eye, and this also weakens the zonules, which makes cataract surgery more complex, and it can also block the drainage part, the trabecular meshwork. And so they're looking as well at whether or not pseudoexfoliation puts you at an increased risk of heart and cerebrovascular disease as well. And then lastly, you can get glaucoma from either infection or inflammation from different autoimmune diseases or infections like syphilis, tuberculosis, and so forth. Okay, so the next thing I'm going to talk about is treating glaucoma, but I didn't know if there were any questions, or if people want, they can kind of use the chat feature, and certainly I'm happy to answer any questions that you may have.
Yes, we can use a chat feature, or it looks like folks who are joining us by phone can also do *6 to unmute yourself, and then we'll be able to hear the question.
And I can also, I'll take questions at the end as well.
Okay.
Treating glaucoma, the treatment depends on the specific type and the severity, and then how the glaucoma responds to the treatment. And so in closed angle, next slide, in closed angle glaucoma, it really begins with creating or performing a laser iridotomy. So laser iridotomy is an in-office laser that makes a small microscopic hole in the colored part of the eye. And you can see, for those of you who can see on the illustration on the right, the colored part of the eye, the iris, is bowed forward. The fluid behind the colored part of the eye continues to be made, but the fluid can't get out and around to the drainage part. And so a laser iridotomy creates a small hole, and you can see the green laser there, which will then allow the fluid to go through that hole and gives it a way to get to the drainage angle of the eye. Again, this can be done prophylactically and preventatively, which is the ideal situation. But if a patient goes into angle closure, this is the treatment to the way that we treat it. And so you can go past the next slide, which is just a video showing that. Open angle glaucoma, or closed angle glaucoma that does not responded. So let me back up. Closed angle glaucoma, you have acute angle closure, which is treated with the laser peripheral iridotomy. You can also get a chronic angle closure, where usually in that case it's not 100% of the drainage angle is closed, but where part of the drainage angle is closed. And so chronic angle closure and open angle glaucoma are really treated the same way, which is medication, laser, or surgery. So I often tell patients that surgery is kind of, if nothing else works, and the first line treatment is either medication or laser. Next slide. In terms of medication, we have 5 different classes of medication. And these are all topical drops. And so we have beta blockers, and the most common being timolol. And all of these medications, and frankly, even the lasers, they work by either decreasing the fluid production, the aqueous humor production, or by increasing the outflow. And so beta blockers like timolol decrease production of the aqueous humor. Alpha-2 agonists like brimonidine decrease production and increase uveoscleral outflow, which is the outflow beyond the trabecular meshwork. Carbonic anhydrase inhibitors like dorzolamide decrease aqueous humor production. Prostaglandins like latanoprost increase uveoscleral outflow. And then the newest class in the last few years, Rho kinase inhibitors like natarsadil, which inhibits an enzymatic pathway in the trabecular, that causes fibrosis in the trabecular meshwork. So that increases trabecular meshwork outflow. So 5 different categories of drops, and there are also combination drops as well. All of these drops have side effects. They all cause kind of, next slide, you're good. They all cause redness, burning, irritation when you instill the drops. Generally, that's a temporary side effect. And then some class-specific side effects. So beta blockers, you have to be careful in patients who have a history of lung disease because they can cause wheezing or breathing problems. They can also cause fatigue, lower the heart rate, just like a systemic beta blocker, and can worsen dry eyes, which is a very common eye condition among patients. The alpha-2 agonists like brimonidine can cause confusion in the elderly, and probably the biggest thing we see with this is 20% will develop an allergic conjunctivitis, and that can be years after starting the drop. So we have a lot of patients on alpha-2 agonists. They work very well, but a lot of them at some point develop an allergy to it, and then you have to stop the drop and can't go back to it. Carbonic anhydrase inhibitors like dorzolamide can cause a bitter taste. That can also, those drops can also worsen dry eyes. And then prostaglandin analogs cause eyelash growth. This was actually used by the drug company to repackage it into Latisse years ago, which specifically was used to lengthen eyelashes. But prostaglandins also darken the color part of the eye and have some eyelid changes, which and some changes in the orbital fat, which can tend to give patients a hollowed out look of the superior sulcus above the eye. Moving on, we also treat glaucoma with laser. We had talked about the laser peripheral iridotomy for angle closure. For if the angle's open, we can do laser trabeculoplasty. And laser trabeculoplasty is a laser treatment to the drainage part of the eye that stimulates the drainage, the angle, the trabecular meshwork to function more efficiently. And you can skip the next slide. The laser trabeculoplasty is probably my favorite first-line treatment for patients who need pressure lowering. You know, drops work if you use them. Even in studies, about 70% compliance with eye drops. And that's even in studies where patients knew they were being watched. So laser trabeculoplasty improves patient compliance. It also improves variability of the pressure, you know, within a 24-hour period. And it tends to be cheaper for patients. You know, I tell patients the laser trabeculoplasty works for about 5 years in 50% of patients. It can work up to 10 years in about 20%. So the efficacy of the laser does decrease with time, but it is repeatable. You can retreat with the laser, although you usually get less length of the effect. So if it lasts for 8 years and you repeat, you might only get 6 years the next time. But you can start to stack some of these treatments. And compared to brand name medications, it becomes cheaper, you know, within a year, in about 8 months or so. And even compared to generic medications, the laser becomes cheaper depending on which generic, anywhere from 1 to 3 years down the road. And so whether it's laser or one of the 5 classes of drops, you know, those give us a number of ways to treat the pressure in open angle glaucoma before we get to glaucoma surgery. But nevertheless, if the drops or the laser don't work, Then we go on to glaucoma surgery. And there are really two classic glaucoma surgeries. Trabeculectomy, which will create a drainage channel for the eye, the goal of which is to kind of stabilize the disease, stabilize the pressure, prevent further damage to the optic nerve, prevent further peripheral vision loss. Although, as we've talked about, it doesn't reverse damage that's already occurred or visual field loss that's already occurred. And it's performed in an outpatient basis. Yeah, we'll skip the video on that. And then the other one is called a shunt or a seton, an aqueous shunt surgery. This is where, whereas in the trabeculectomy, you're making a opening from inside a small opening, but from inside the eye to outside the eye, but under the conjunctiva. So if you look at the eye, there's a white part of the eye, that's the sclera. And then there's a clear layer over top called the conjunctiva. I'm sure everybody's familiar when you get pink eye and the conjunctiva gets real red and irritated. And that's we call conjunctivitis. But in these surgeries, you're trying to get fluid from inside the eye to outside the sclera, but still under the conjunctiva. And so the trabeculectomy, you make a small hole through the sclera into the front of the eye to allow fluid to drain, and then you suture up the conjunctiva, and you try to get a bleb or a reservoir whereby the fluid is now, some of the fluid is draining outside the eye that way. Patients who are prone to scarring and some other risk factors as well may not be the best candidates for that. So those patients, we oftentimes do a aqueous shunt, whereby an aqueous shunt has a tube that we again insert into the eye. So now instead of the fluid just going through a hole, it goes through a tube to an extraocular reservoir that is, again, between the sclera, the white part of the eye, and the conjunctiva. And so the tube, as long as the tube stays open, fluid will drain through there and into the reservoir. And as I said, it's performed in patients who are at high risk of trabeculectomy. You can skip the next slide. And both of these procedures have a lot of complications. In large trials conducted, at academic centers with, some of the most well-known glaucoma surgeons in the country, there's about a 30% complication rate with these surgeries. And so the complications include low pressure. So we do these procedures to lower the pressure, but sometimes we lower it too much. And then wound leak, whereby as I said, you want to get the fluid from inside the eye to outside of the sclera, but not all the way outside the conjunctiva. So some of these patients develop wound leaks where fluid goes from inside the eye all the way to completely external to the eye, and that can lead to a high risk of infection. Bleeding inside the eye, called a hyphema, swelling of the cornea, the front windshield of the eye, having a reservoir or a bleb outside the eye that becomes encapsulated, so there's no more room to hold any more fluid, having a bleb that leaks, and again, you have a leakage outside the eye, endophthalmitis, which is where you get an infection inside the eye. And then in the aqueous shunts, either tube erosion, where that tube wears through the conjunctiva and is exposed, which increases your risk of infection, or double vision. And so because of these, all these complications, in the last 10 to 15 years, we've moved on to some what we call minimally invasive glaucoma surgery, or MIGS. And MIGS procedures, there's a trade-off. They have a much better safety profile with fewer complications and more rapid recovery time than the trabs and the tubes. However, they don't lower the pressure as low as what the trabs and the tubes do. So these are excellent surgical options for patients with mild to moderate glaucoma who have failed laser and pressure lowering drops. They're not a great option for advanced glaucoma patients who need to have their intraocular pressure lowered more than what a MIGS procedure can do. And there are different types of MIGS procedures kind of outside the scope of this talk, but trabectome, iStent, ECP or endoscopic cyclophotocoagulation, Cook dual blade, and canaloplasty. And there are more of these coming out every couple of years. And so some of the take-home points: glaucoma is controllable. Vision loss can usually be prevented if it's detected and treated early. And if a patient's prescribed eye drops, they have to take them regularly for them to work. And if they're at risk for glaucoma, they should visit the ophthalmologist regularly. And so what does regular eye exams mean? Next slide. So adults with no signs or risk factors for eye disease should get a baseline screening at age 40, and then you can kind of go from there. People at any age with ocular symptoms or risk for eye disease should be seen more frequently. Next slide. And these can include patients with diabetes, patients with high blood pressure, if they're on steroids, if they have a family history of eye disease. Glaucoma, there are a lot of eye diseases that affect your central vision. Patients can't see the eye chart as well. These eye diseases tend to cause symptoms, and they tend to be recognized by patient and other healthcare providers. But glaucoma can be just as disabling. I give the example of some patient with very advanced glaucoma who can see the 20/20 line on the eye chart, but they can only see one letter at a time. They can't see the whole line at the same time because their peripheral vision has progressed so much that there's just this central island of vision. And somebody like that, is not legal to drive a car, probably does okay in their house or in a familiar surroundings. But if they're in an unfamiliar surrounding, particularly in low lighting situations or bad contrast, that level of peripheral vision loss is very much debilitating, and they can have a lot of problems with daily tasks with that. Very good. You can do next slide. It's just sort of the cover sheet here. And so that is all that I have. Thank you again for allowing me to speak with you. I'm certainly happy to answer any questions that you may have.
Excellent. And again, if folks would like to have any questions, *6 will unmute you, or you can also put your question in the chat as well. I do have one question. I have someone wondering about what is your thought on any supplements or dietary changes that could be helpful for someone who has glaucoma?
Yeah, so there really isn't dietary supplements that have been shown to help glaucoma. There very much is in macular degeneration. It is true that there's some very loose indirect correlation between blood pressure and intraocular pressure. So we do recommend to patients that they have some aerobic exercise a few times a week. And in general, things that are good for blood pressure can be good for the eye pressure as well. In terms of supplements, there was years ago, it was thought that marijuana would lower the eye pressure, and recreational marijuana actually does lower the eye pressure. But what we have now seen with the legalization of marijuana is that it's really the THC component that lowers pressure. The CBD component actually increases pressure. And so just as I was saying that I have patients who come in who have been whose pressure is high and they've been using steroids, I do have patients come in who's I've followed and their pressures are fine. I may not even be following them for glaucoma, for something else, and their pressure all of a sudden goes up, and we kind of recheck it a couple weeks later and it's still up, and they haven't been on steroids, and we kind of go through all the things. I do actually ask about recreational marijuana use, and I have a handful of patients that started recreational marijuana and their pressure went up, and then they stopped it either because it didn't give them the effect that they want, or that they were concerned about their pressure and the pressure came back down. So that that's sort of a supplement, if you will, that you also have to be careful with.
Okay, very good. Does anyone on the call or online have any questions? Otherwise, I do have some more that have been submitted to me. Okay. I see someone with this number of 610-455-3878. Do you have a question? No? Okay.
Bill, I think you unmuted yourself. Do you have a question?
Yes, I do. Can you
Hey,
hear
we
me?
can hear you. Yes,
Yeah.
perfect.
Thank you. You're right. I did mute myself. So my question is this. I heard the doctor mention that steroids used for like injections for like I've had an injection in my shoulder, I've had an injection in my back, can raise pressure. How significant of an effect is that? And the second question I have too is I recently had the COVID shot, and I felt the vaccine, and I felt that the day after that my vision was really hazy. And is that a common thing? It seems to have gone away, but because it triggers the immune system, I wonder if that then causes the inflammation, which then made my vision hazier.
Yeah, so I'll take those in reverse order, I guess. I don't know the physiology of the vaccine itself kind of causing some blurry vision. You know, with the virus itself, we occasionally saw conjunctivitis. That was a very early sign in China with some of the, early patients who were very, very sick in the ICU with the virus itself. And it does, you're right, it can kind of rev up the immune system. I have not seen any kind of iritis, which is sort of when the immune system gets revved up in the eyes, or anything with the vaccine. We do occasionally, patients who have had the virus, we sometimes do see some peripheral retinal hemorrhages, which are kind of self-limited and they go away in patients who have reported having the virus. So certainly the virus can affect the eyes. I'm not aware of the vaccine necessarily having any ocular side effects. In terms of the steroids, it's really, first of all, some patients are more predisposed to what we call a steroid response. So a lot of patients could get steroids, could get injections, and their pressure would never go up. But there are definitely some people, patients with glaucoma are more likely to be what we call steroid responders, where steroids will increase the pressure. There's a wide variability, but classically this takes a couple of weeks, 2 or 3 weeks, for the pressure to go up. And then when you stop the steroid, then it takes the same amount of time, so classically a couple of weeks, for the pressure to come back down. In the case of like a cortisone injection, obviously it's a one-time injection, but from that we count, okay, if this cortisone is expected to last 3 months, how long did it take for the pressure to go up? And similarly, then, we expect that it'll take that much, once the cortisone wears off. And so patients who get an injection here, because of the fact that this steroid response tends to be self-limited in normal eyes or even eyes predisposed to glaucoma, it generally doesn't cause much of an issue, even if your pressure goes up for a few weeks. Patients of mine who are kind of brittle glaucoma patients who have a good amount of damage, or who just seem to, when the pressure goes up, they get damaged quicker than kind of what's classically seen. Those patients, if they have any exposure to steroids, we usually check their pressure in the office about 2 weeks after, and then it depends on the situation, but we'll kind of follow them every couple of weeks, just because in those patients we know if the pressure does go up, the optic nerve is more at risk for permanent damage.
Okay.
Thank you.
All right. Thank you. I have another question submitted here that I was asking about if you have any good tips for getting drops in the eyes. I would imagine if someone's struggling with that, that would impact how well those drops work then as well.
Yeah, so that's a great question. I would separate that into 2 ways that you have trouble with drops, right? So one way is just getting the drop in the eye, and that, I definitely have tips. The way I tell patients to do it is to look up and pull down on the eyelid and try to put the drop just on the inside of that eyelid. That way, because they're looking up, they're not looking right at where that bottle cap is coming. And because the drop is kind of hitting the inside of the eyelid or the bottom, the eye isn't quite as sensitive to the drop. If you have somebody who, that if somebody's self-administering the drops, most people can do that, but you still get some people who just can't put drops in their own eyes. Certainly, if there's a caretaker there, that method works for pretty much everybody. And so if they're self-administering, they still can't get it in, or sometimes we see this with children too, where they're just squeezed so much you can't get the eye open. For those patients, I recommend having them lie on a bed, kind of keep the eyes closed and put a drop right in the corner between the eye and the nose with the eye closed, and then just open the eyes. And then there's only one place for that drop to go, which is to run in the eye. The other place, besides just having trouble getting the drop in the eye, the other place that we see difficulty with eye drops is in the elderly population, particularly if they have arthritis of the hands. And some of the drops, bottles, the ophthalmic drops tend to be small bottles. And so sometimes you have to squeeze with a decent amount of force with that. There are some third-party devices. There's one called a nano dropper, which just recently came out, which has less drop come out of the bottle. And so that's good because it also preserves, more of the drops. So it's in the long run a bit cheaper. There are some third-party things that help you, kind of squeeze the bottle. But to be honest, that tends to be a much harder workaround than just somebody who can't get the drops in the eyes.
Okay,
And
very
that's,
good.
sorry, last thought on that. That's just someone who we will, really try to either do the laser where they don't need drops, or if they need drops, try and get them on drops that are once a day rather than 2 or 3 times a day. So just trying to find a medication regimen that's less often for those patients.
Excellent. And I just want to check again, does anyone else on the call have a question?
I do.
Hi, Karen. Is that Karen?
Yes.
Go ahead.
Karen.
Go ahead, Karen.
Yes, you were talking about the shots before can affect and increase the pressure. What if you're getting shots like for your knee for arthritis?
Yeah, so if it's cortisone, any steroid-based any steroid-based shot, absolutely. Now I know
But
sometimes
they're recurring, like every 6 months, approximately.
Right. Yeah, so again, those will be patients that could, those would be patients that could be having pressure spikes, that are temporary. So say they get them every 6 months and the shot lasts 3 or 4 months. Well, maybe, maybe they're having pressure increases months, say 2 through 4, and then they're okay again, and then they get another shot. And so depending when they see us, the timing might be such that the pressure is okay. But yes, absolutely. And that's not, it's not, I don't see it every day or even every week or month, but I have a handful of patients a year that exactly has that exact thing whereby they get cortisone shots regularly and they have some optic nerve changes, and I look back and their pressures are pretty good. Most of the time they might have a high one here or there, and you start to kind of map out and start to see them more frequently. Like I said, someone like that we would see 2 or 3 weeks after the cortisone injection, just to check the pressure in the eye and make sure that pressure that they haven't had a steroid response. And by the same token, somebody who is kind of checked, who has that and is checked a couple times and okay, the pressure is not going up. Again, a lot of patients do not have a steroid response. So somebody like that is at very low risk. I wouldn't say you'd never need to check them, but they'd be at very low risk for developing steroid-induced glaucoma because if the steroids don't increase the pressure like that. Probably a slight increase in incidence of increasing the pressure as they age, as they get into more elderly years. But yeah, so it can go both ways.
All right, thank you.
Yeah.
Okay. Are there any other questions for Dr. Chronister? And again, if you have any questions and you're on the phone, *6, or as well as you can raise your hand or put your question in the chat if you're joining us online. Okay. We certainly can take questions later. If you have them, we'll make sure to get some answers for you. But otherwise, we'd like to thank you, Dr. Cronster, for your presentation today with us on glaucoma. Do you have any closing thoughts or anything that you'd like to share?
No, thank you so much. Sorry for some technical difficulties in the beginning, but I'm glad we got those worked out. And thank you all for your time, and have a great day.
Excellent. And again, thank you all for joining us for our presentation today from VisionCorps. If you're not yet working with us at VisionCorps, or if you'd like to reconnect with us, you may call me directly at 717-205-4146, and I'll make sure to get you connected to our services to help you restore any lost independence. Thanks, everyone, and thank you, Dr. Cronster.
Thank you. Take care. Bye
All
now.
right, bye-bye.